when you come off of the high of all of those estrogens when you're pregnant, that's a really like bottleneck kind of trigger time for autoimmune disease.
Welcome to the Dutch podcast, where we dive deep into the science of hormones, wellness, and personalized healthcare. I'm Dr. Jaclyn Smeaton, Chief Medical Officer at Dutch. Join us every Tuesday as we bring you expert insights, cutting-edge research, and practical tips to help you take control of your health from the inside out. Whether you're a healthcare professional or simply looking to optimize your own well-being, we've got you covered. The contents of this podcast are for educational and informational purposes only. This information is not to be interpreted or mistaken for medical advice. Consult your healthcare provider for medical advice, diagnosis, and treatment. Hi, I'm so glad you're here with me on this week's episode of the Dutch podcast. This week I have one of our very own, Dr. Allison Smith. I'm here to talk about something that we see all the time reported in, and we see so many patients who ask questions, and that is all of the inflammatory symptoms that we see during perimenopause and menopause. Things like joint pain, increased risk of injuries, itchy skin, allergies that crop up, and even autoimmunity. We see such a rise of that in this time of life. And so the question is this related to the changes that we see in hormones, estrogen and progesterone? And what else comes into the story? Today, we're going to give you that comprehensive story and really walk you through everything that you need to know about the role of estrogen, progesterone, androgens, and then cortisol and the HPA axis when it comes to balancing the immune system through perimenopause and menopause, because we know this is such a big time of change for women. We cover so many different topics. You're going to walk away with a lot of pearls, even things about itchy ears, that annoying symptom that so many women report. Dr. Allison Smith completed her education at the National University of Natural Medicine in Portland, Oregon. She worked in private practice, focusing on primary care and women's health. And over the last 10 years, she's shifted really just into the lab space, the hormone testing space, and she has a breadth of experience consulting with providers on thousands and thousands of cases in the context of women's health and hormone testing. She does a lot of teaching, webinars, case presentations. She writes a lot of articles, and I'm really proud that she leads the Dutch team, and I'm really proud that she leads our clinical education team here at Precision Analytical. Welcome, Dr. Allison. I'm so glad you're here, Allison, partner in crime. I'm so excited to get this time to talk with you on the podcast, and it's going to be a fun episode.
It is going to be fun. Ever since I wrote a piece on immune and what happens in perimenopause when people go through, people want to know about this. People have lots of questions. They want to understand autoimmune risk. And so I'm so excited to talk about it today.
Totally. I mean, I frame it up a little bit, but that's one thing that I think is like a mystery to women in perimenopause, where they get frozen shoulder or tissue injuries. They're getting hurt more when they work out. They're having trouble recovering. There's like these physical joint related issues that rise in perimenopause and menopause. And then, like you said, there's like autoimmunity as well. So we're going to cover all that today. I want to start with like physical injury and that side of the immune system, and like, why do our tissues weaken? What can we do about it? Because I think that the more, I am pushing into this phase of life myself.
Me too.
I just realize like how important movement is for my sanity, for my physical health. And I think we're talking about that all the time, which is such a healthy thing. We're talking about like women should be lifting, women should be working out, women should be walking, moving. But if you get injured more easily, it can be such a hard thing. It's hard to heal. You have pain. Exactly. So let's talk a little bit about, like, lay it out for us. What's going on during this time frame that leaves us more susceptible to injury?
Yeah. I mean, you got to think about what's happening to our hormonal system, first of all. So let's unpack that first. So we have kind of the lay of the land of what's happening with the hormones that might be putting us more at risk for these types of injuries. In our cycling years, our bodies get really used to estrogen cycling. So estrogen, yes, is wildly different from one phase of the cycle to another, but the body has all of these checks and balances for that. Progesterone is coming up with ovulation, and progesterone is sort of like a modulator of estrogen's activities in the tissues. It's a time of high androgens when we're younger, which also sort of if you think about it, is sort of a reservoir for more estrogenic activity. If we need it, the body can tip the balance towards conversion to estrogens. And our cortisol system is pretty consistent throughout life. So we have a diurnal rise and fall of cortisol. It's something that doesn't necessarily decline as we get older. However, when we hit perimenopause,
we break.
right? We start to break. Estrogens often become more dominant because the brain is having to scream a little bit more at the ovaries to do its normal job. We have, an ovarian reserve that's starting to decline a little bit, and the health of those follicles is starting to change. They're aging. They don't respond as readily and as easily. And so they instead sort of respond to increasing FSH levels in sort of fits and starts in a way. So those estrogen levels become less predictable. Our progesterone levels start to drop with every cycle that we have. And it's not, an overt change at first. You might still have some pretty good progesterone levels throughout a lot of your perimenopausal transition, but if you were to plot your progesterone every cycle over time, over the 10 years before your last period, you would see that progesterone level is declining, and that's normal, but we lose some of that ability to temper down estrogen's activity, and it's a modulator of estrogen, so it can help to improve our response to estrogen, and it can also decrease it. And then our age-related decline of our androgens too is just like the final hit, right?
Like
Our
testosterone,
yeah,
DHEA.
exactly, which is our sort of estrogen reserve in a way. Aromatase can activate uh, androstenedione into estrone, and then testosterone into estradiol. So as a way for the body to, get that activity from estrogen. So when those things all sort of coincide, but cortisol is kind of doing its normal thing if we're not stressed, even just that shift in balance can shift us more towards inflammation and immune dysfunction over time. So with that in mind, think about early perimenopause. What's happening? We typically are a little bit more estrogen dominant than we used to be when we were cycling because progesterone levels are declining a bit. DHEA levels are starting to decline with age, right? We've hit 40 probably. And so we have that lower reserve. And estrogen we think of as a potent anti-inflammatory, in the system. And really it's an inflammation modulator. It's a sign that there may be some inflammation going on if your estrogen's high. But it also is an immune modulator, and it kind of stimulates our immune system to be more responsive to injuries or to any infection coming into the body. So it's a responder. So if we were estrogen dominant during that time, we might be over responsive to injury, right? So I think that that's kind of what we start to see with a frozen shoulder. And especially when we find ourselves in a low cortisol state, if we're chronically stressed and we have cortisol that's not as responsive, that together with a high estrogen can kind of put us at risk for some of those issues that you're talking about with degenerative joint issues. And I sort of resonate with the frozen shoulder because I know my mom really struggled with that. She'd play tennis. She was,
Right.
in her 40s, and she just was having to have cortisone injections maybe every, I don't know, at least once a year, maybe twice a year for frozen shoulder. So I remember that.
Yeah.
Yeah.
I mention it because it's now documented that there's
Yeah.
higher rates of frozen shoulder in peri and postmenopausal women. It's such an interesting, strange phenomenon. And other shoulder soft tissue injuries, like rotator cuff tears, for some reason the shoulders seem to be disproportionately affected. But
Yeah.
it's also a very complex joint with a lot of different movements, so it's very easy to injure. But just another reason why it's so important to stay so strong.
That's right. That's right. And, yeah, a cortisone injection is great and it's going to get you through that. But if you can treat the underlying issue, if it is a hormonal issue, you can identify these things and we can go after it in a preventive way.
Yeah. So, I mean, can we talk a little bit about with these hormonal changes? You talked about how sometimes it causes an increase in inflammation. And then also because it's a modulator, it can actually reduce
Yeah.
reactivity as well. So, let's talk a little bit about inflammation as a place to start. Because I think a lot of people wonder about the impact of inflammation and the role that hormones play in inflammation. And we know there's a lot of documented immune system changes. Like I think about even pregnancy. Like there's documentation that people who have autoimmune conditions, it actually resolves during pregnancy, or sometimes it gets worse during pregnancy, depending on the woman. But there's definitely changes that happen in response to these fluctuating hormones in life.
Yeah. But then when you come off of the high of all of those estrogens when you're pregnant, that's a really like bottleneck kind of trigger time for autoimmune disease
Particularly
to right
Hashimoto's,
after you. Yep.
right? Like postpartum
Yeah.
thyroiditis. It can be Hashimoto's or it can be non-immune related, but very, very common in postpartum for that to be a time for it to flare up.
Exactly. So I think it's these fluxes in hormones, and which is also a hallmark of perimenopause, where estrogens are doing this throughout the perimenopausal timeline, and like maybe each of those fluctuations is like a trigger point for immune dysfunction. And a lot of women, I think, present to the clinic with issues like I have itchy skin, or I
Itchy
have,
ears. That's another one that's been
itchy
documented.
ears.
Itchy ears. What a weird symptom, but it is actually a symptom of perimenopause.
Yeah, but I think it's
Yeah.
that like that balance tip towards immune activation and that estrogen dominance during that time. Because estrogen is so stimulatory to the immune system, you can get these sorts of symptoms, and even like
Mm.
too much histamine kind of a response in the skin. And some people end up on, antihistamines for long term during perimenopause because they're not really realizing that they just need some darn progesterone or, some sort of, adrenal support to kind of get the other side of that equation.
Mm. So, what are some early signs, like in early perimenopause, that clinicians should watch out for or should be paying more attention to? That might be a sign that the patient in front of them, or if you're the patient, for you, that patient in front might be starting to experience some immune dysregulation.
Yeah, I do. I also think about, yes, the itchy skin, the skin changes, but I also think about even the joint issues that you're talking about, not recovering quickly enough from
Mm.
exercise and, having more injuries. It tells me about that inability to deal with inflammation appropriately. And I also think about even sleep issues as
Mm.
being possibly related to.
That's a really good one.
Yeah, because histamine is related to sleep, and
Right.
interleukin-6 has a diurnal rhythm that can be disturbed by estrogen dominance. And so I think, if sleep issues and even daytime fatigue, maybe somebody says, well, I sleep great. I don't think I have any sleep problems, but they're tired all day. It may make sense to look into their sleep metrics or think about estrogen dominance and perimenopausal hormone shifts as playing a role there.
I want to talk about sleep a little bit more because I think that's a really interesting one because people don't think about the role of like immune system and inflammation on sleep disruption,
Yeah.
but it is really impactful. And then I think you layer on top of that cortisol dysfunction, which, is something that, you can experience where you get these cortisol surges at night
Yeah.
that wake you up. But I think if your body is in a state of, high reactivity, high inflammation, high immune response, there is a risk that could trigger cortisol to be released in the
Exactly.
core time as well.
Yeah. Well, and it also triggers, whenever cortisol is triggered, cortisol is a powerful immune suppressor, right? I always think of like estrogen and cortisol or like Captain America and the Winter Soldier. They're kind of working together and like putting out the fires that one person's saving someone, but they are hurting someone else, and they're able to kind of pick up after each other for the greater good. And I think they do work together in that way.
Mm-hmm.
But when there's an imbalance with cortisol is maybe too high at night, you can have all this collateral damage, right, with blood sugar dysregulation and other things that can sort of stimulate immune activity as well. So it's a tricky balance, is really what we're looking for and why we even test this stuff to begin with. Even though we know the trajectory of these hormones as we're going through perimenopause, why do some people do it gracefully and others have a really hard time? I think if we tested everyone, we would know the answer to that question.
Mm.
Some people just have better progesterone levels as they're going through perimenopause, or they have a more resilient diurnal free cortisol curve, or maybe their estrogens always stay in range, but they're, anyway, I think we could have a better handle on this if we were actually looking at these things.
Yeah, definitely. I mean, one of the things that, I know estrogen really helps to keep the immune system in check. And I think there is this kind of conglomeration of things that happen where you talked about blood sugar regulation. I think that's an important piece to pull in. While it's not a hallmark or problem associated with menopause per se, it is commonly paired together with hormonal change, right? That's
Yeah.
a time in life when you're in your 40s and 50s and 60s where you really start to see metabolic health problems rise up in people who haven't really been as attentive to it. So I think women oftentimes are going through metabolic syndrome paired with perimenopause. hopefully we're doing lifestyle stuff. If you're working with a naturopath or a
Yeah.
functional medicine doc where you're really staying ahead of the curve. But for the general population, we see that a lot. And estrogens actually really kind of keep the system in check. And they
I was
really
gonna
do.
say that. It
Yeah,
covers
I
up a
think
lot of
about it
evils.
as
Yeah.
like it's like the gloss or the sheen that
Yeah.
kind of keeps the bubble from bursting. And then when you lose that, it's like it can wreak havoc.
It's exposed. Yeah.
Yeah, absolutely. So that's another piece of that is that you're almost like lifting the veil when the estrogen goes away. You're like removing that container for inflammation. Like you said, it's like it's really can act like a fire extinguisher in the body.
Exactly. Yeah. Yeah.
So when do we talk about, I mean, we've talked about pain and joint pain. Are there any other elements of that you think are important to talk about?
Yeah, I think the sleep piece is a really big part. And I think how our gut microbiome changes, I think it's a time where people might have new food sensitivities or new, allergies. And I think that's a really common reason people will come into the office is like their asthma is worse or their, you know, yeah, the
Their
itchy skin,
allergies
the new
are,
food
they've never
sensitivity.
had seasonal allergies and
Yeah.
now they have seasonal allergies.
Exactly. Yeah. And I think, you can tie it almost directly to that drop in progesterone. Progesterone is another thing that sort of covers up a lot of
Can you talk more
um
about that?
yeah, so estradiol is stimulatory to the immune system, and part of the immune system is our mast cell system, which is surveilling all of our barriers. And so we think about the skin barrier when you come into something that you're come into contact with something that you're maybe sensitive to or that you don't want on the inside of your body, you have a response to that. And the mast cells play an important role in releasing histamine. And histamine gives us that characteristic wheels and hives reaction that we all know. Maybe even worse reactions. But typically, people will feel like that allergic skin reaction with histamine, and so that is increased by estrogenic activity. So you might have more of that during follicular phase when estrogen is really dominant. When progesterone comes in, progesterone acts in the opposite way. So it tempers estrogen's effects on mastocytosis. So we get fewer mast cells, less mast cell degranulation, less histamine. And it's this really nice balance of how, or it's a demonstration of how progesterone tempers down estrogenic activity. So as progesterone decreases in perimenopause, we have more opportunity for histamine levels to increase. There's so many other pieces of histamine I feel like that can make people more predisposed. Not everyone is going to have this sort of immune forward presentation of perimenopause. And I think people who have maybe like a gut dysbiosis coming into perimenopause, for instance, already, and maybe kind of leaky gut setup because of how estrogen levels are starting to vary quite a bit. In progesterone, we're losing some of our lactobacillus. With estrogens, we're losing some of our biodiversity. And so the gut microbiome is changing, and that also changes the way we respond, right, to outside
Yeah.
pathogens. So I think there can be like a perfect storm of things. Even people with methylation issues, that's another thing. Genetics wise, if you have poor methyltransferase enzyme genetics, for instance, you might not clear your histamine very well. So if you are having a histamine reaction, you're not going to be able to inactivate histamine systemically as well as the average person, and that could put you more at risk in perimenopause. So it could be, perfect storm.
I love that you're bringing up all of these different confounding factors because it's like it just goes to show it's not straightforward. And
No.
this is probably part of the explanation of why these immune flare ups happen for some women and also not for other women. So I want to talk a bit more about the microbiome because I know we're a hormone podcast, but the gut's really important
It
for
is.
hormones and definitely for the immune system. And it's so interesting because in menopause or postmenopause, when they look at the microbiome of women postmenopausal, it actually looks more like a male gut, whereas in a cycling female, it's really unique. So there are these changes, and I've done a lot of work research into this area. It's so interesting, but hormones cause shifts in the microbiome, and also shifts in the microbiome cause changes to hormones. So it is this like cat chasing its tail going on
It's
in the gut.
bidirectional.
That's right. Yeah, and then during pregnancy, there's actually a complete kind of clearing of the diversity of the gut. So, like I'd mentioned before, pregnancy is another time where we see a lot of immune change, and it's actually very interesting to look into that because the gut, if you look at it, it looks like a dysbiotic gut. There's like very low diversity, actually a lower count of microbes in the gut during pregnancy, which is in response to these hormonal changes and probably it ends up creating a leaky gut state in the
Yeah,
gut, hyperpermeability, but probably that's evolutionarily beneficial because the whole idea is that when the gut is leaky, everything gets through. So when you're pregnant, it can emphasize like all of your nutrients being absorbed.
that's right. You
So
need a
there is an evolutionary explanation, but there's a downside to not having a diverse, strong gut
That's right.
microbiome.
That's right. Well, and I think as our gut microbiome does change over, we have this sort of midpoint, you know, and I think some people have more overgrowth of certain bugs. I always think of like Bacteroides fragilis, and oh, there's a Streptococcus version of that same family. And I think when we think about the bacteria in our gut, they are metabolizing estrogens. That typically they're not synthesizing them from nothing, but they are, they're taking those estrogens, since we're talking about estrogen, and they're metabolizing them down. They can change estradiol into estrone, or they can change estrone into 16-hydroxyestrone.
Mm.
And if we have a microbiome that is rich in organisms that express beta glucuronidase enzyme, we can then reabsorb a lot of those estrogens back into the bloodstream. And if we have fast metabolism of estradiol in the gut by these gut bugs, and they're making a lot of 16-hydroxy, and we're bringing 16-hydroxy back in, that can really affect our risk for even autoimmune diseases, which I think is really interesting.
Mm.
So a lot of interplay between what's going on in the gut, what's going on systemically, and how they're married together, and how that ends up manifesting in the person that you're looking at in front of you with these symptoms.
Definitely. I want to talk a little bit more about the HPA axis, and I think this is an area where, in particular, on our team, you are my go-to expert in this area. Like
I love this.
your clarity of communication, your driving passion to talk about it, and I think the main takeaway for listeners to start with is just how important the HPA axis is for overall health, particularly during perimenopause and menopause. And there's so many interesting mechanisms by which the HPA or adrenal axis interacts with the HPO axis. We were just talking about one of them at Dutch Fest, where it's like when you have a lot of stressors, the brain, the hypothalamus and pituitary, the signal that comes out that speaks to the adrenal glands, ACTH, stimulates the production of cortisol, but also of DHEA from a separate area within the adrenals. But they're not always linearly released together, but that's that same hormone that stimulates both. And there can be a lot of additional androgens made when there's a lot of stress, and it can really impact the overall hormonal picture in so many ways.
But it
Can
all
you?
modulates.
It all
It's all
modulates,
designed
right?
to like check and balance each other.
That's right. So I want to like really, I know that's like we're talking about this, and this is not just an HPA axis episode, it's an immune episode,
Right.
but I want to really explain to listeners how these things are connected, and I just don't think there's anyone who's better than you. Can you start by just talking about the HPA axis at a high level? And I'm thinking about like probably most of our listeners and practitioners utilize a diurnal pattern. Like they'll take a salivary cortisol, but there's so much more to it at the tissue level of what's happening. Let's maybe start with those basics, and then I want to pull it back to the immune system.
Yeah. So I think, it's pretty well understood that when we're under stress, the body recognizes those cytokines and chemokines that communicate with the brain that we're under stress and we need cortisol. We need an adrenal response to this. And CRH is made in the hypothalamus as a response to that, which is a corticotropin releasing hormone, talks to the pituitary gland, tells it to make ACTH, which is the corticotropic hormone that goes to the adrenals and says, it's time for cortisol and DHEA. So then we have all the upregulation of those genes that are encoding for cortisol and DHEA. They get produced and then they're in circulation, ready to hit the road and be taken up by tissues and bind their. Sometimes they have DNA, especially cortisol, will have these response elements right on the DNA, and they just upregulate genes kind of directly. There are also glucocorticoid receptors. The alpha receptor responds to cortisol by upregulating genes in a different way. So lots of cool ways that we respond to that, like stress hormone. And we can measure free cortisol levels in circulation by looking at salivary levels of free cortisol. And we can also look at free cortisol in the urine, which also has a diurnal rhythm, and which is similar but looks a little different because when you're looking at urine, if you take a sample of the first morning void, you're looking at what was produced and circulated and excreted during the night while you're asleep, of course. So your first point of the day is not the highest point of the day in urine. So always remember that when you're looking at urine versus saliva, but they're both free cortisol and they give you an idea of what's going on with cortisol throughout the day. And if you have, let's say you're devoid of, any major stressors during the day, your cortisol should be higher in the morning than it is at night when you go to bed, right? And you should reach the lowest point of all of the day when you're asleep, basically. In the middle of the night, your cortisol should just be like the quietest, lowest nadir it would be all day long.
Yeah, you're sleeping. Hopefully you're not having some stressful dreams.
Yeah, exactly. Well, you never know. We can test that. But then cortisol has to be taken up into tissues in order to have a tissue response. Who cares if it's in circulation?
Right.
It's got to be taken up into tissues. It has to have an action. And there isn't a fabulous way to measure receptor activity or, what genes it turned on or whatever. But we can look at how it gets metabolized, whether you're mostly making cortisol or cortisone. And we can look at these things as they're being excreted and we say, oh, this is interesting. You have a really strong pull over into active cortisol. I wonder what's going on. So a lot of times we'll look to the metabolites, the way it's being metabolized, how much is being metabolized, because essentially with cortisol, we're looking for highs, is what I say, and if you're seeing a free cortisol pattern that's maybe normal or it's low and flat in somebody who's inflamed or they have a lot of stress, when you look at the cortisol metabolites, they're usually pretty high. They might be telling you a different story.
Let's talk more about that. I want to kind of pause because I think this is an area where you're moving into territory that a lot of people don't know about. So I want to just slow it down. What you're saying is diurnal curve is the free cortisol. That's basically what's available to act. And I think cortisol has binding proteins basically, just like everything else with sex hormone binding globulin. So when you're thinking about cortisol that's free, you're seeing the amount that's available to the tissue. Now you're shifting, and on the Dutch test, you see that on the left. If you shift to the right, you can see cortisol metabolites, which on the first page is the bottom right dial, and that sometimes is out of sync with what you'd expect to see with free. And tell us what that means.
Exactly. So when your free cortisol is much lower compared to the metabolites, that suggests that the production of cortisol was really high. You took up a lot of cortisol in the tissues, but you metabolized it very quickly.
And you're burning right through it, right?
Right. You're burning through it as fast as you can get it. And that's a body adapting to high cortisol. Why would the body want to adapt to high cortisol? When you think about what cortisol does in the body, it does a lot of good things, but it also does a lot of bad. It does at the expense of a lot of other systems. So, we think of cortisol as catabolic, it's tissue wasting, it breaks down bone, so that we can run away from the thing that's going to kill us. Other body systems are going to suffer long term.
I always told patients cortisol is kind of like a fire extinguisher, and you want to have it handy so you can quickly release and put out a fire. But another way to think about that is if you don't control it, you would have foam everywhere, and that would be a problem. And that's what ends up happening when you have all this cortisol around. That foam is starting to cause a problem. It's degrading your furniture, like you said, eating away your bones. So there has to be some way to kind of control that if it's around all the time. That's one of the ways that I always talk about it. I like to give these little tips because it can be hard to explain
It
physiology
is.
to patients, but they have to take it home in a way that means something to them.
Yeah.
Yeah.
But, your body is adapting. It's
Right.
very smart. Your body knows what to do in chronic stress. And that is a way that you can identify as a healthcare practitioner when you are testing cortisol is you kind of owe it to your patients to look a little bit more deeply than the free cortisol pattern, which can only tell you how much free cortisol is available to tissues.
Mhm.
But you can't see the other side of that, like the body working so hard to keep it
Yeah.
where it is,
Right.
Yeah.
It's fascinating. That particular piece I think is worth double clicking into because I think, well, when I was in practice full time, I ran like just a salivary
Yeah.
cortisol. And
That's
I
what we
think most
were
of us
taught.
did. That's what we were trained in.
Yeah.
And we thought we were doing a great job. But now that I've seen so many Dutch tests and I see them metabolize cortisol, I think about how many patients I thought were high or I thought were low because
Yep.
their free cortisol was high or low, but their metabolites don't match that. So what that tells you is the production of cortisol is actually much, much more or much,
Well,
much less than it looks like on the curve. And the problem is that you have all this tissue adaptation going on.
exactly. Exactly. I think of all the ones that were normal. You
Exactly.
know,
That's what I'm saying. And you're like, oh, actually, we
oh,
weren't
yeah, your
normal. We
curve
just
looks
didn't look in the
normal.
right
I guess
place.
there's nothing wrong here. So,
Yeah. I'm sure
that's
some of the
weird,
people that are listening are like, yeah, my curve looks normal, but I don't feel normal. Maybe I need the
right?
Dutch test instead of just the salivary.
Yep. Dig a little deeper. Yeah.
Absolutely. And so this is really important because I think, and one thing that I found really interesting, I studied medical anthropology in college, was that in menopause, there are some cultures that do not report symptoms at all. Most traditional tribal cultures, they don't report like even hot flashes, let alone all these other problems. So it gets me thinking about the lifestyle. And of course, it's not just stress, it's also diet, movement, etc. But I think,
Environment.
yeah,
Yeah.
there's so much that's different. But I think about, that entering into perimenopause, it's a really good time to go into preparation mode. It's like preparing for the
Check
apocalypse.
your stress.
Yeah,
Yeah.
like checking your stress is one of the most important things that you got to do
Yeah.
here. It's like prepare for the apocalypse. It's not the apocalypse. It's not that bad. But the more prepared you can be going in, the more resilient you can be to in all different ways. You're going to be able to handle those hormonal changes and hopefully, particularly if you're inflamed already
Yeah.
and you have signs of chronic inflammation like allergies, eczema, asthma, autoimmune conditions, or even like I think about even elevated ANAs, anti-nuclear antibodies. Sometimes they can be high, but not high enough to hit a diagnosis.
Yep.
Like I just think all of those are signs that we should be paying attention to those fundamental things that would be lowering inflammation.
Exactly. And is that tying to estrogen dominance and cortisol
Mhm.
dysregulation? Yeah, probably. This is the right time. And a lot of us are taking care of our aging parents and we're still raising kids and we're in the busiest working time of our lives and we're like whatever compounded stressors
Yeah.
happen in our 40s, so like everything you can kind of control or at least be mindful of and create a space for yourself to kind of release some of that
Mhm.
stress, I think is so important.
Yeah. Can we talk about that stress system? Because, like, for some women, obviously, the HPA axis is balanced enough or cortisol secretion's appropriate where that balance is maintained.
Yeah.
And then for other women, it's not, and
Haywire.
inflammation starts to go haywire. What makes the difference? Or like what would you look for on a Dutch test even, or what would you look for in a patient sitting in front of you to identify that this woman is more likely to be
Dysregulated.
okay or dysregulated? Yeah, either
Yeah.
way.
I always ask about sleep. I think sleep is probably the biggest one. I think if you have someone in front of you who is prioritizing their sleep, and they're able to fall asleep and stay asleep through the night, and
Mhm.
they're getting, I don't know, 8 hours would be great. But even if we're like over 6 hours, 6 to 8 hours of sleep per night, six really sounds bad. 6.5 to 8, let's say. Let's not make six a goal. But I think, that makes a huge difference to cortisol. And then, people who have a sound dietary approach, like a
Mhm.
nice whole foods diet, lots of plant foods during the week, eating fish, a lot of the stuff that we think of as just being like baseline foundational good health practices for eating. I like to hear that people are eating breakfast, I hear somebody say, "I'm never hungry until 11 AM," I'm like, "Cortisol,
Because
let's look at it," you know? There
you're waking up with it surging and
Mhm.
it's suppressing your appetite. Okay.
Exactly. Yeah. So I think you can listen for things like that, or like, "I just don't get tired until 2 in the morning." Huh, cortisol, and sympathetic nervous system activation is really tightly tied to cortisol and our HPA axis. So those are the things I listen for.
I love those suggestions. Just on the sleep piece, one of the takeaways that I really love is I've been utilizing HRV or heart rate variability, which almost every tracker
You would
looks
hate
at.
my heart rate variability.
You hate it?
Oh, I hate mine. Mine
Oh.
mine's so poor.
Yeah, but it's a great sign. I mean, I
Yes.
think like I love that you're looking at sleep, and I always think about our resilience. How can we measure resilience? And I think the HPA axis measurement, like on the Dutch test, is the gold standard
Yeah.
supreme, right? It's so much better than. And actually, let's talk a minute about serum AM cortisols, because I think if someone's never seen a functional medicine doc and your doctor orders that, is that useful or not? But hold that thought for a second.
Yeah.
The HRV is like a day-to-day measure of how well you're doing on the stress
So much better.
management
Yeah.
scale. So it's measured, it's basically, we should have more variability in our heart rate through the day. It shows that we can respond to a stress like a fight or flight, and then we can come back down to normal. Normally, it's the latter part, it's the come back down that we struggle with, but it's the turning on and off of the sympathetic fight or flight, parasympathetic rest and digest nervous system. So when you have a good HRV, it's showing that you can go back and forth like that. And we use the heart rate as a measure because when we're in fight or flight, our heart rate goes up. Now, if you are, like apparently you, Allison, and
If you're
definitely like
me and your
me,
heart rate variability is 12 this morning.
yeah, it's a sign on the day to day
Yeah.
of how you're doing with that. And I really love that as a measure, because if you are working on stress, it can be really hard because you're like, no, I don't really feel that stressed. I'm good. I'm
Yeah.
good. But then
That's
you have
always me.
HRV
I'm
as
good.
like a data measurement
Yeah.
of how you're doing with that on top of all the sleep measures. So I love to put that out there. I am also flunking this class. It's like this health class, especially right now with everything going on in life. But it's a really good measure, and I think such an important thing for particularly like high functioning women to be working on.
Yes, to monitor. Yeah. Yeah.
Yeah,
I wonder what HRV does with burnout. Because we kind of know what cortisol does in burnout. The car kind of flattens
yeah.
down and, really characteristic. And I bet heart rate variability has some connection
I'm
there to
sure it goes
burnout too.
down. Yeah, we can look. We should look into that.
Yeah.
But now, can you talk a little bit about AM cortisol and whether that has value in this screening process
I think AM cortisol is the way to go if you're suspecting
for
adrenal
serum?
insufficiency,
Okay.
maybe, like really extremely low cortisol. However, it's not going to tell you much other than that, unfortunately. But the thing about serum cortisol is that it is mostly bound, unavailable to tissues. It gives you kind of a total cortisol production. So it gives you that piece, which is nice to look at against the free cortisol
Yeah, could
pattern.
it be different? It could be very different than the
Yeah.
free.
But
Mhm.
it almost always is completely different
Yeah.
from free. It's almost always normal. And when it's not, let's say it's a little bit low, a lot of times you'll do a Dutch test or a salivary cortisol diurnal pattern. You're looking at the free fraction, and a lot of times the body is keeping that completely normal to tissues. You can take a low total production and have a completely normal free bioavailability because the body controls cortisol binding globulin.
Mhm.
And so, there's so many checks and balances that allow free cortisol to stay normal for a long time while production goes down or while, metabolism is working hard to keep it normal. So it is helpful, I think, to look at both sides of it. You can look at a total cortisol in serum, but you don't want to stop there ever
Mhm.
for an adrenal, like a full adrenal assessment. You always want to follow that up with a free cortisol diurnal pattern and the metabolites and get a sense of what the cortisol clearance rate is to really get a sense of how cortisol is functioning in the body.
Yeah, that makes a lot of sense.
Yeah.
Now, on top of stress impacting hormones and estrogen and progesterone, androgens, and those reproductive hormones impacting inflammation, there's also a direct connection between stress and inflammation.
Yeah.
We talked a little bit about cortisol's anti-inflammatory activity, but what about the effects of chronic stress on people's immune system?
Yeah. I think acute stress is really simple. acute stress, we have all of those cytokines and chemokines speaking to the brain and the upregulation of the HPA axis and cortisol coming out and fighting the fight. But when it comes to, chronic inflammation, it's a little bit different. The body starts to sort of shut down its response to cortisol and even to estrogen's activities. I mean, if estrogen's too high for too long, ER alpha and ER beta receptors, which act kind of differently. ER alpha is kind of the gas, and ER beta is like the brakes. They start to be expressed differently and in different relative levels. And so it changes our response to estrogen. Same thing happens with cortisol. The glucocorticoid receptors, the alpha kind, are like the gas, and the betas are far less responsive, maybe not even responsive at all. And so even though you might have normal cortisol levels, you could have a vastly hindered response when it comes to immune suppression. So
That's interesting. It's a
ineffective.
lot like even insulin. I think people know the
Yeah.
insulin model, right? You have this hormone insulin that when blood sugar is super high and insulin super high, the cells become resistant. That's where you have insulin resistance, meaning that insulin doesn't do its job as well at the cells level. At the issue is the tissue, right? It's
Yep.
happening at the cell level. So what you're describing is really the same thing happening
Yeah.
with cortisol. It's like the cells are not responding to cortisol, which could mean the cells are on fire and the cortisol is being released to try to put that fire out,
And
but
it can't.
the signal's not getting there.
Exactly. And that's when you get these runaway, inflammatory presentations, and, maybe the cortisol looks okay, but it's not getting the job done. Then you kind of know, oh, this is probably glucocorticoid resistance. Usually you'll see elevated cortisol metabolites on the test, whether cortisol is normal or usually it's, trending low or flatlined on the free cortisol pattern when this is happening, right? That's a very common chronic stress pattern. We used to call it hypermetabolism. Now we call it high cortisol clearance rate, is very, very much indicative of that, like chronic inflammatory, chronic immune, kind of response.
Well, you've really naturally transitioned us to the Dutch test, which I want to talk about this in depth because I think people think about the Dutch test. And this is like if you're a provider and you're using the Dutch test, this is where you want to really listen. If you've
Yep.
been like in the car listening and you're, half paying attention, now's the time to really pay attention. Come to class. Okay. So when you're looking at the Dutch test, I think people understand the basics of, I know how to read what's happening with estrogen, progesterone, androgens. Cortisol, I think, is a little tougher concepts from what we hear from providers. We've talked about that. But I want to layer in that there are a lot of patterns that we see that we talk about this with like our clinicians on our team. We see thousands of reports because we review reports before release, especially anything that looks out of the ordinary. And then we're looking at test reports all day long with customers. So with our physicians who are calling in for support on their reports, we look at hundreds and hundreds a week of patient cases. It's a lot of Dutch tests. And through this, you start to see patterns with different conditions. Like there's patterns with PCOS that go beyond just the androgens. There's patterns in people who are obese that go, that you can see that
Or
are
you can see it immediately before you even look at the
immediately.
requisition. Yeah.
And I think that is some of the gold. And of course, our test is not diagnostic. It's not like you're running a HSCRP.
Right.
However, these patterns are suggestive to us that that patient has something going on underlying. I want to spend the rest of our time on our podcast today talking about those because I think, especially when it comes to immune balance, you wouldn't think about Dutch test being an immune test, but it really does give a lot of insight into what's happening with the immune system. So can you talk a little bit about what we see with an overactive immune system or a lot of inflammation? Are those different, or you talk about them all together?
Um, I think it's good to talk about them all together. I
Okay.
think, the obvious one is the cortisol piece. Like our brain goes straight towards the stress system, right? Cortisols, you're looking for high cortisols, whether they're captured in the cortisol metabolites or they're captured in the free cortisol that's hitting the tissues in the diurnal pattern. We're looking for highs typically. If you're seeing a lot of lows, low everything, you're looking at somebody who is like end of the road.
Like they've been through the high
They've
phase
been
and
through
you're,
the highs. Yeah,
yeah.
exactly. And at that point you're seeing usually a flatline curve, a low or absent cortisol awakening response and very low cortisol metabolites. At that point usually that patient feels really crummy. and they can't mount an immune response appropriately anymore, and they can't manage their inflammation, and they're usually have a number of diseases that are usually being treated by lots of different medications, and they can be difficult to manage if you don't get those cortisols out of the tank. But most people are going to be coming in with some presentation of high cortisol, whether it's free or in the metabolites. So you want to identify that pretty quickly and go after that using anti-inflammatory supports primarily, and also adrenal adaptogens to make sure that the HPA axis remains ready to participate in the negative feedback loop, right? Which gets disturbed with chronic stress over time. The not so easy part, or not so intuitive part, is what high cortisol and stress does to some of our other hormone systems as well. So we think about aromatase is an enzyme that changes our androgens into estradiol and estrone. It is upregulated by stress and cortisol. So, if we have more aromatase activity, moving our androgens into estrogens, you're going to see estrogen dominance. You might see high estrogens even. And even though estrogen has some really important roles in controlling inflammation, it tends to be anti-inflammatory, but it can be both pro and anti-inflammatory, depending on the tissue needs. It's a sign that there is inflammation, right? So we think about estrogen when you see it dominant in a patient, especially with low progesterone or low androgens, and that estrogen's really kind of the sticking out like a sore thumb, especially with high cortisol. That should be a big sign, like, oh, I'm looking at inflammation here.
I bet a lot of people are thinking about their patients and how often they see the estrogen
So
dominant
much.
presentation.
Yeah.
And I think we naturally go to phase one metabolism. But if you have looked at patients like that with estrogen, and estrogen dominance is not a scientific term, let's just put that out there. We're talking about a relative comparison of estrogen to progesterone as far as like where they'd fall in relationship to other women their age.
Yeah.
It's not a scientific calculation. So I want to put that out there because I think
No.
a lot of people utilize it like it is one and it's not a disease state. And I want to be super clear. But these are patterns that we see when we are looking at hormones in totality. So I bet a lot of you were like, oh, yeah, I have so many women with estrogen dominance. I never really thought about the fact that inflammation could be a driver for that.
Could be a driver. And then I also think about some of the organic acids that we look at on a Dutch test too.
Yeah,
Like,
this is an area not a lot of people know to look. So I'm really glad
yeah,
you're raising this.
yeah, quinolinate is probably one of the most sort of potent markers of inflammation on our test. It's actually itself is a neurotoxin in the system when it builds up and is high chronically. So we have to be really careful with high quinolinate levels. And they show up in the urine when you're inflamed. And so it's a really great marker.
Now I know it says it's neuroinflammation,
Yeah.
but is it, and can you just talk a little bit about, because I get that question a lot, is it only inflammation in the brain that causes quin to be high or
No.
also systemic?
Systemic inflammation, but because it is a neurotoxin, it can cause neuroinflammation. And I think that's why we call it a neuroinflammatory marker, right? It's very much active in the CNS for sure. So, but yeah, inflammation is the driver. You will almost always see it elevated in patients who struggle with obesity. So that type of inflammation that's, systemic and coming from adipose tissues, especially central adiposity, you'll see pretty high quinolinate levels. Really, that entire pathway, if you think about quinolinates really coming from tryptophan, and tryptophan metabolism to serotonin being hijacked in a way by some of these inflammatory cytokines that are upregulating the enzyme conversion of tryptophan on down into the kynurenate pathway, which goes all the way down to form NAD, which is,
So important.
cofactor to everything.
All right.
Right? It's our
Yeah.
de novo niacin synthesis in the body,
Right.
essentially. Yeah. But on the way to NAD, we have all these stops along the way. So if you're low in B6, you might build up in some of these like xanthurenate and kynurenate. And then when you're inflamed, there's an enzyme that converts quinolinate into NAD that can't function properly when we're inflamed, or we have phthalate exposures is another reason. So there can be like toxic exposures that slow that enzyme down. But when you build up in quinolinate, not only is that caused by inflammation, it can cause inflammation too. So
Fabulous. We love when things happen like that. Yeah,
yeah,
it gets bad and then it just makes itself worse.
that's right. I think of
Mhm.
melatonin too as kind of an inflammatory marker when it's too low, because melatonin is is an anti-inflammatory in the body. If you have low melatonin, it is suggestive of, oh,
My light went off. Sorry,
oh
you're gonna have to
no,
repeat that.
it's
Sorry.
okay.
Okay. Sorry about that, everybody. Okay, back to where we were.
Back to work. Um, yeah, I think about melatonin in particular as a pretty nice inflammatory marker. If it is low, really, even if it's high as well, probably
Mm.
endogenously, it maybe could be a sign that the body's working a little bit too hard to leverage some of its antioxidant potential, but definitely low. If your
Yeah.
melatonin is too low, right, it's a sign that maybe cortisol is high, since they sort of oppose one another. And yeah, so that's a good one to look at too.
Great. I mean, there are so many different patterns that can be seen. And I want to point out a resource we have. If you are a Dutch provider, if you're currently a customer, you can log in to the portal, the provider portal, and under education, we have these mini guides. And we have mini guides that go into some of the patterns. We have one for insulin resistance, we have one for inflammation. So I encourage you to look at those, and it teaches you a little bit about what you might see on the Dutch test, kind of like what Dr. Allison's going through. And then on the backside, there's actually a checklist, which I find so helpful because you can look at it next to a report and actually see how many of the changes that we see associated with that pattern your particular patient has. And it can really be helpful to be like, okay, is this a problem or is it not a problem here? So I would definitely check out those resources online if you're a Dutch provider. And if you're not, become one because they're free, even if you don't order a test.
Yeah, and look at it against your perimenopausal patient lab results. I think it makes a lot of sense, especially if they have sleep issues or skin issues or, joint issues or any of these that make you think inflammation, or new allergies and that sort of thing. So,
Great. Well, it's been awesome to cover all this today. I think there's a lot of nuances to perimenopause and menopause that affect women, the women that come into our offices that are asking us for help, that the connections aren't as clear as being just directly related to low progesterone or low estrogen. So I love that we had the chance to cover this topic in more depth. So thank you so
me
much for
too.
your
We
time.
could probably go further into androgens next time.
Yeah, we need more time. We can cover androgens even more,
Part two.
but we'll have to make time for that. It's
Yeah.
definitely let us know, you guys, as you're listening, if you want to hear more about androgens and inflammation and perimenopause as well. So thank you guys so much for joining us today. Thank you, Dr. Allison, for joining us. If people want to get access to you and pick your brain about their patient cases, they can call into Dutch. They can
Yeah.
book an appointment with you or with any of our docs on our team. And I highly encourage you guys to do that. It's a free service that we offer. It's unlimited, and you can get support on the Dutch tests that you're ordering. If you want to talk, especially if you're newer in ordering, you can talk them
Yeah.
through with our provider team, and everybody is fabulous.
We
And they're
love to
really,
nerd out on hormones and
we sure
functional
do.
medicine. So,
We
yeah,
sure do. And we get paid to nerd out on
we
hormones.
do.
Life could not be better.
We could not.
If you guys like what you heard today and you want to hear more, I encourage you to subscribe to our podcast wherever you listen to them, and make sure you follow us on social at Dutch Test. We would love to hear from you. And if you want to join us, we launch a new episode every Tuesday. So hopefully we'll see you next week.